Hi, my name is Osama. Naga will continue the Pediatric Board Review series with Respiratory Disorder chapter. You can follow with me the Pediatric Board Study Guide Respiratory Disorder chapter from page 291 to page 311. My objective or my goal in this lecture to discuss the spirometry, upper airway diseases, congenital lung diseases, respiratory tract infections, asthma and cystic fibrosis, and a few other subjects. We'll start with pulmonary function test spirometry. A spirometer is a device measures the volume of air inspired and expired by the lung. It's a simple mouthpiece and connected to a software to any computer or a specific device. The instruction, you ask the patient to take a full inspiration or maximum inhalation. Then you ask the patient to exhale as fast as possible. Then continue exhaling for at least 6 seconds. And you repeat this process 3 times. Then you record or you consider the maximum value. So again, maximum inhalation. Then exhale as fast as possible. Continue exhaling for at least 6 seconds. Then you repeat the process 3 times and you record or you consider the maximum value. The most important values measured by the spirometer is force vital capacity and force expiratory volume in the first second FEV1 and the ratio of both values. The force vital capacity or FVC is the volume of air expired after full inspiration with maximum expiratory effort. FVC, it is usually normal or slightly decreased in the cases of asthma or obstructive lung disease, but it is usually reduced in the cases of restrictive lung disease. Force expiratory volume in the first second or FEV1, it is the volume of air expired after full inspiration with maximum expiratory effort in the first second or in 1 second. So it is exactly the same definition of FVC, but the recording in the first second or in 1 second. This value, FEV1, it is reduced in both obstructive lung disease or asthma and restrictive lung disease. In the cases of restrictive lung disease, it is reduced because of decrease in lung volume. And in the cases of asthma or obstructive lung disease, it is reduced because of increased lung resistance. FEV1 to FVC ratio is the most important tool to differentiate between obstructive and restrictive lung disease. It is the percentage of vital capacity which expired in the first second of maximum expiration. It is usually normal or near normal in the cases of restrictive lung disease, but it is usually reduced in the cases of asthma. So it is reduced in the cases of asthma and normal or near normal in the cases of restrictive lung disease. Force expiratory volume in the first second or FEV1, it is reduced in both cases, restrictive and obstructive lung disease. FVC, it is normal in the cases of asthma and reduced in the cases of restrictive lung disease. Major values measured by the spirometer which will help us to make a diagnosis: FEV1, FVC, FEV1, FVC ratio, flow volume loop, FEF 25 to 75%, which is the force expiratory flow, 25 to 75% of the force vital capacity. It is a sensitive indicator of obstruction or asthma. It may be the only abnormalities in cases of mild asthma. So why this is important? Because sometimes you have all these values are normal and this is the only abnormal value, and will help us in the diagnosis of mild asthma, and we'll see that in the next few slides. Let's understand and learn how to read the volume or exhale volume curve. The exhale volume curve, the x-axis is time in second, and the y-axis is the volume in liters. So when you ask the patient to take a deep breath, then start to exhale with maximum effort, this patient will be able to expel 75% of the air out of the lung in the first second. So if 75% of the force vital capacity will be out in the first second and the rest is afterward. The patient with asthma, in this green curve, this patient is taking much longer time to be able to exhale or expel the same amount this normal patient did in the first second. So this patient did it in 1.5 seconds or more. And then, but at the end, this patient also is having normal forced vital capacity, as most of the patient with asthma they do. Most of the patient with asthma, they have normal forced vital capacity. This patient with severe asthma is taking very long time to exhale the air out of the lung, and at the end will have a slightly reduced forced vital capacity. The patient with restrictive lung disease, because of reduced lung volume, they have reduced FEV1 and markedly reduced FVC. So the FVC is always reduced in the restrictive lung disease. So this curve represents restrictive lung disease. This is severe asthma. This is mild asthma. This is normal. Flow volume loop. Flow volume loop. The bottom part of the flow volume loop represents the inspiration, and the top part represents expiration. When you are using the spirometer, advising the patient to take a deep breath and full inspiration, the curve starts to form in this direction till it reaches the point where the patient cannot breathe in anymore, and this area or this site represents the total lung capacity. Then you advise the patient to exhale as fast as possible. The curve starts to ascend rapidly to reach the peak expiratory flow rate, then start to descend in a nice shape straight forward down to zero, where the patient cannot exhale air anymore, and this represents the residual volume. So this side represents the residual volume, and this side represents the total lung capacity. So the descending curve, very important to recognize that the descending curve should be straightforward or slightly convex. In cases of obstructive lung disease or asthma, you will see the descending lobe is concave, and the more concave or the more the concave is the descending curve, the more severe is the asthma. Like this is another example of case of severe asthma, and you will see here the indentation or the concave shape is more severe or markedly reduced, as you see here. But the patient with asthma, they will keep the inspiratory lobe normal. So this is a case of mild to moderate asthma. This is a case of severe asthma, and even here the PEF or the peak expiratory flow rate is reduced at this in the cases of severe asthma. So again, descending curve is concave is asthma. The more the concave, the more severe is the obstruction and more severe is the asthma. In cases of extrathoracic obstruction, the inspiratory lobe is the one will be affected, not the expiratory. So if extrathoracic obstruction, the best and the classic example of that is vocal cord paralysis of variable extrathoracic obstruction, and the inspiratory lobe will be blunted and the expiratory lobe will look normal. In cases of restrictive lung disease, the shape of the lobe will look normal, but the size will be markedly reduced and shrunk. So the curve will be shrunk because of the generally the patient with restrictive lung disease, they have low lung volume, so, and reduce the total lung capacity. So you will see here the curve looks normal shape, descending, not concave, no indentation. And also inspiratory curve will look normal, but generally both they look smaller than normal if you compare it to the normal curve. So this is normal. This is a concave shape in the descending lobe, represent asthma. This is more severe asthma. This is a blunted inspiratory curve, represent variable extrathoracic obstruction. The best example of that is vocal cord paralysis. This is a normal shaped lobe, but markedly reduced or shrunk. This represents restrictive lung disease. How to understand the values presented in the spirometry? First thing, to identify the FEV1 to FVC ratio. If this ratio is normal or high, you are dealing with normal lung or restrictive lung disease. If this ratio is low, you are dealing with obstructive lung disease or asthma. So then evaluate the FVC. If the FVC is normal or high, this is a normal lung. But if it's low, this is a possible restrictive lung disease. If the ratio is low of FEV1 to FVC, evaluate the FVC. If it's normal, this is asthma. And remember, most of the cases of asthma, you will have normal FVC value. If it's low, this means severe asthma or severe obstruction or mixed with restrictive lung disease. Let's practice few cases. I will start with normal case first. If you look at here, the flow volume loop is ascending and descending, and normally is not reduced in size, and the shape is normal, is not concave or coving, and the inspiratory lobe also looks normal and is not reduced in size or blunted. And if you look at here at the volume time curve, also it looks normal, reaching the 75% of the exhaled air in the first second of forced vital capacity, and reaching the normal value of forced vital capacity at 6 seconds. So this is a normal volume time curve. This is a normal flow volume loop. This is a very practical way to understand how to read the spirometry. From where to start? As you see here, there's a lot of values. Start with the FEV1 FEVC ratio. So this is where you start. And look at the reference. The reference here is 90. The recorded value here is 100. So you have normal FEV1 to FEVC ratio. Here actually is higher than the reference. So you are dealing with either two things: normal lung or restrictive lung disease. How to know the difference? By checking the FEVC. If the FEVC is normal, this is normal lung. If FEVC is low or restricted, this is a restrictive lung disease. So here the reference is 1.48 and the recorded value is 1.6, which is more than the reference. This is normal. So you are dealing with normal lung. To confirm, especially in mild cases of asthma, read the FE F 25% to 75%. See if it's normal or low. So here the reference is 1.61 and the recorded value is 2.27, which is normal. So this is a normal spirometry. This is the same but in older child. Here another example or another case. This is the flow volume loop, as you see here, is going up normally. Then in the descending loop is more concave, and this is a classic example of asthma. And after the treatment, the patient responded very well to the bronchodilator, and the descending lobe here is normalized and less concave. So this is a classic example of asthma or reversible airway disease, responded very well to the bronchodilator. And the inspiratory lobe here looks normal. And in the volume time curve here, you will see the forced vital capacity here is normalized after the treatment. And the difference here, as you can see, the patient able to exhale more volume of air in the first second than before the bronchodilator. But both of them, they have normal forced vital capacity as most of the asthma patients. Spirometry reading, where to start? We start with the FEV1 FEVC ratio as we learned before. So start with that and look at the reference range is 86 and the recorded value is 74. So 74 here is less than the reference value. So this is abnormal. This is reduced. This is asthma. And the next step is to check the FEVC. The FEVC reference value is 2.13 and the recorded value is 2.68, which is normal. So this is also confirmed. This is a classic case of asthma, as most of asthma patients, they have normal FEVC. Also, you can look at the FE F 25% to 75%. The reference is 2.07 and the recorded value is 1.22, which is low or reduced. So this is also confirmed that it is asthma. And also to see if this is a reversible airway disease, you will give a bronchodilator. After the treatment here, you will see a difference. If you look at the FEV1 to FEVC ratio, 74 improved to 87, and the difference here is 18%, which is significant for reversible airway disease. Responded well to bronchodilators. And the same thing also with the FEF, 25% to 75% responded very well to the bronchodilator, and you see here the value is more than double, which is 115%. Here is another case. If you look at here at the expiratory flow volume, the expiratory curve looks normal, but when it comes to the inspiratory, here is very flat and blunted, and this is abnormal and represent a case of extra thoracic obstruction. And the best or the classic example of that is vocal cord dysfunction, or extra thoracic obstruction. This is another case. If you look at here, normally the flow volume lobe should be in this direction, but here is markedly reduced, is a shrunk, but it's still keeping the normal shape. So there is no concave, there is no indentation in this area. And also the inspiratory lobe looks normal shape, but is reduced in size. So totally the flow volume lobe looks normal shape, but is shrunk and markedly reduced. And here also in the volume time curve, the FEV1 is reduced and the forced vital capacity is markedly reduced. And this is a classic example of restrictive lung disease. So let's see how we can read that in the spirometry. This is the recorded parameters of the previous case. We start with FEV1 to FVC ratio. The reference is 85, the recorded value is 79, so this is near normal. The next step is to check the FVC. The reference here is 2.47 and the recorded value is 0.62, which is markedly reduced. So you have normal or near normal FEV1 to FVC ratio and markedly reduced the FVC. This is consistent with restrictive lung disease. Also, if you look at here, FEF 25% to 75% is markedly reduced, and this value can be or this parameter can be reduced in both cases, in restrictive lung disease and obstructive lung disease or asthma. The way to make the difference is always to check first FEV1 to FVC ratio. Pulse oximetry is very helpful in many respiratory conditions. It measures the partial pressure of arterial oxygen, which is the percentage of binding sites of hemoglobin with the oxygen attached. It's a very small and handy tool you can use even in the medical office. The correct reading of pulse oximetry can be affected by many factors you have to keep in consideration. For example, dyes, nail polish, high intensity light, impaired perfusion or hypoperfusion, for example heart failure, hypothermia and sepsis. This condition can give you false reading on pulse oximetry. Methemoglobin and carboxyhemoglobin also can give false reading. So if you suspect any patient with methemoglobinemia or carbon monoxide poisoning, do not use pulse oximetry for assessment because it can be normal and does not reflect the patient condition. So the best way to assess these two conditions, methemoglobinemia and carbon monoxide poisoning, is arterial blood gas, not pulse oximetry. If you would like to measure the oxygen status or the metabolic status of any patient, the best blood gas to order is arterial blood gas, not capillary, not venous. Inaccurate reading is very important to keep that in your consideration. If the specimen permitted to remain warm outside, what happened? The white blood cells will consume the oxygen and will give false acidosis. So the specimen has to be tested immediately and not to be left outside in warm environment. We'll start with few symptoms of the respiratory or common few symptoms of the respiratory system, and we'll start with the stridor. Stridor is a high-pitched sound because of turbulence of airflow in a partially obstructed upper airway. The location of obstruction determines the type of stridor. If above the glottis or above the level of the glottis, what is the glottis? Is the vocal cord fold. This will give you inspiratory stridor. So mostly when you have any obstruction above the glottis will give you inspiratory stridor. At or immediately below the glottis will give you inspiratory, expiratory, or biphasic stridor. Biphasic stridor. Inspiratory stridor suggests laryngeal obstruction or obstruction above the glottis. The classic example is epiglottitis. Biphasic stridor suggests obstruction in the glottis or the subglottic area, and the example of that is croup or bacterial tracheitis. Expiratory stridor suggests obstruction of the tracheobronchial tree, and expiratory stridor equal word wheezing, and the classic example is asthma. This table is to differentiate between very important causes of stridor. The first one is epiglottitis. The site of obstruction in cases of epiglottitis is supraglottis, above the glottis or above the vocal cord. The age of presentation is 2 to 6 years of age. The onset is rapid and fast. The type of stridor is inspiratory but can be biphasic stridor as well. These kids, they look very sick. They have toxic appearance associated with drooling, leaning forward. They have anxiety and they are scared. The hoarseness of voice is rare in this case. The most common cause of epiglottitis is Haemophilus influenza bacteria. However, this cause is less frequent because of vaccination, and also other bacteria can cause epiglottitis as well. Laryngotracheobronchitis or croup is very common, and the site of obstruction is subglottis or below the glottis. The age of presentation is 6 months to 36 months of age. The onset is slow, can be preceded by runny nose or viral infection or upper respiratory tract viral infection, barking cough, but can be presented also suddenly in the middle of the night with sudden onset of stridor and severe respiratory distress, and this can be frightening to the parents. The type of stridor is biphasic, inspiratory and expiratory. These kids, they do not look toxic as in the cases of epiglottitis and bacterial tracheitis. Not associated with drooling. Hoarseness of voice is common. The most common virus is parainfluenza virus. The bacterial tracheitis is a severe condition and should be taken seriously. The site of obstruction is in the trachea. The age of presentation 3 months to 6 years of age. The onset is rapid and fast. The type of stridor is biphasic, inspiratory and expiratory. These kids, they look very sick. They have toxic appearance associated usually with high fever. Not associated with drooling. The hoarseness of voice is possible in this case. The most common bacteria isolated in the cases of bacterial tracheitis is Staph aureus. Causes of acute stridor: laryngotracheobronchitis or croup, foreign body aspiration, bacterial tracheitis. This is a 2-year-old boy who has fever, sore throat, dysphagia, and neck pain for 2 days. In physical examination, he has a stridor, neck stiffness, and retropharyngeal bulge. On CT scan, in this case, you will see here hypodense oval area here and with peripheral rim enhancement, and this is highly suggestive of retropharyngeal abscess. Generally, this space or retropharyngeal space should not exceed the size of the vertebral body, and this is also very highly suggestive if you do not have this hypodense area, is suggestive of retropharyngeal abscess as well. Know that this space or retropharyngeal space is connected from the skull down to the mediastinum, so this can be associated with epidural abscess as complication, or down to the mediastinum with mediastinitis and many other complications as well. This is a plain film soft tissue view of the lateral neck. If you see here, you will see widening in the soft tissue in the prevertebral space, and the anteroposterior diameter exceeds the size of the adjacent vertebral body. So this is a classic presentation of retropharyngeal abscess. The hint here, or the things to remember, that the anteroposterior diameter of the prevertebral soft tissue in children should not exceed the size of the vertebral body or the adjacent vertebral bodies. Retropharyngeal abscess is common in children, on young children younger than 6 years of age. It has abrupt onset of high fever, difficulty swallowing, refusal to feed, sore throat, hyperextension of the neck or stiffness of the neck, respiratory distress. Retropharyngeal abscess may present with rash, and if you have rash and retropharyngeal abscess, you should consider Kawasaki or scarlet fever. It is rare but should be considered in the differential. Management: ensuring the airway patency, supplementing oxygen is very important, and intubation in the cases of difficulty breathing and airway obstruction. CBC and the blood culture should be withdrawn before starting antibiotic. The antibiotic or empiric therapy should cover for gram-positive, gram-negative, and anaerobes. So ampicillin, sulbactam, or piperacillin, tazobactam is an excellent choice. Clindamycin as well. Once this condition is suspected or diagnosed as retropharyngeal abscess, ENT consult is necessary. Most of the cases with retropharyngeal cellulitis may respond to the antibiotic alone, but once the abscess is formed, need to be aspirated. So ENT consult is necessary as soon as possible, especially if there is airway obstruction. Peritonsillar abscess usually present in adolescence and pre-adolescent age. They present with severe throat pain, trismus, and difficulty opening their mouth. This is very unique about this condition. Trouble swallowing or speaking. They have hot potato voice. Contralateral displacement of uvula and the deviation of the tonsil. Incision and drainage usually give immediate relief. This is a clinical diagnosis and usually do not require any imaging study. This table is to differentiate between retropharyngeal abscess and peritonsillar abscess. Retropharyngeal abscess, they present earlier in age, so less than 6 years of age. Peritonsillar abscess in adolescence. In this case of retropharyngeal abscess, they present with fever, throat pain, neck stiffness. In the cases of peritonsillar abscess, fever, throat pain, and difficulty opening their mouth. This is very unique. So the age and the child present with throat pain, not able to open the mouth, is suggestive of peritonsillar abscess. Here you have the purulence or the abscess formation in the retropharyngeal space. Here the purulence or the abscess formation in the tonsillar fossa associated with deviation of tonsil because of enlargement and pushing the uvula to the opposite side. They may require imaging study, and imaging study is very helpful in the diagnosis of retropharyngeal abscess, especially if you cannot see the retropharyngeal bulge. In the case of peritonsillar abscess, the clinical diagnosis, you can see it and it's very obvious. So you have adolescent present with fever, throat pain, not able to open the mouth, hot potty voice. You will see the tonsils is enlarged. One tonsil is larger than the other, pushing the uvula to the opposite side. This is a clinical diagnosis, do not require imaging study. Another cause of acute stridor is spasmodic croup. Spasmodic croup is common in children between age 1 and 3 years of age. Its recurrent or nocturnal croup occurs at night, begins suddenly and resolve rapidly, so comes and goes quickly, and may be associated with gastroesophageal reflux because the acid can cause laryngospasm, allergies, or psychological factors. So consider that when the condition comes and goes quickly and with no other symptoms associated usually with reflux, so consider reflux, allergies, or psychological factors. We'll start now with the cause of chronic stridor. Laryngomalacia is very important to remember. It's the most common cause of inspiratory stridor in neonatal period and early infancy. It accounts for about 75% of all cases of chronic stridor. Clinical presentation exacerbated by crying or feeding. Placing the patient in prone position with the head elevated will improve the stridor. So if you place the patient in their tummy, this will help to improve the stridor, and this can be done in the office. Supine position worsen the stridor, and the parents will tell you that as well. Diagnosis of laryngomalacia, it's a clinical diagnosis, especially if the patient presents with typical inspiratory stridor, worsen when supine, normal cry, not weak cry, normal growth and development. Clinical diagnosis is reasonable in this case. But if the patient has or present with moderate to severe obstruction, difficult feeding and breathing, unable to gain weight, or you suspect associated anomalies, laryngoscopy and bronchoscopy will be necessary in this case with ENT or pulmonology consult. Management of laryngomalacia. Laryngomalacia is usually benign and self-limiting, require only reassurance. Improves as the child gets older, between 1 to 2 years of age. But remember, you have to advise the parents that this condition in the beginning may get worse before it gets better. So they have to consider that. Is very important for teaching. Careful observation and growth monitoring for most of the patient, especially if it's associated with other anomalies. Surgical correction only considered in severe cases. Clinical case scenario. This is a 2 weeks old boy presents with biphasic stridor for 1 week. So 2 weeks old presents with biphasic stridor for 1 week. No fever, he is gaining weight, no weak cry, physical examination is normal, chest x-ray shows normal lung and normal sized heart, but noted right-sided aortic arch. Stridor is persistent and do not change with position or bronchodilator. What is the most likely cause? Laryngomalacia, tracheomalacia, subglottic laryngeal web, vascular ring, or gastroesophageal reflux. The keyword here, early presentation after birth with biphasic stridor. There is no weak cry, so the vocal cord is okay, and the x-ray also shows normal and size heart. The right-sided aortic arch. So know that vascular ring commonly associated with right-sided aortic arch or double aortic arch, which can cause complete circle around the trachea and the esophagus. Here also the stridor do not change with position, so it's not laryngomalacia or bronchodilator. The most likely cause here is vascular ring. So early presentation, no weak cry, right side aortic arch, or another keyword, the double aortic arch, do not change with position or bronchodilator. This is your keyword for any case present like that for vascular ring. Vascular ring. The most common types of complete vascular ring is right-sided aortic arch and double aortic arch. Usually presents with stridor after birth when the vascular ring encircles the trachea and the esophagus. Any patient with interruption or abnormalities of the aortic arch or present with vascular ring should be investigated for DiGeorge syndrome 22 chromosome 11 deletion. Vascular ring usually presents with noisy breathing after birth. This noisy breathing or the stridor do not change with position or bronchodilator, and this can make the difference between the laryngomalacia or tracheomalacia and stridor because of vascular ring. A chest x-ray may reveal the location of the aortic knob. MRI and CT scan are the best diagnostic studies for detailed anatomy of vascular ring. Echocardiography can show the anatomy of the aorta and vascular rings as well. Barium swallow will show the indentation or may show the indentation on the esophagus. The treatment of vascular ring is always surgical. Another cause of chronic stridor is vocal cord abnormalities. The second most common cause of stridor in infants is vocal cord abnormalities. Unilateral cord paralysis is usually congenital, secondary to birth trauma, surgical trauma such as cardiac or cardiothoracic surgery. Know that unilateral vocal cord paralysis present with weak cry. This is very important in your differential diagnosis. Weak cry and stridor is vocal cord paralysis until otherwise is proved. The stridor is biphasic stridor, inspiratory and expiratory. It is louder when the patient is awake and improves when laying down with the affected side or the paralyzed vocal cord side is down. Bilateral vocal cord paralysis, it is more serious than unilateral one. Usually presents with high-pitched biphasic stridor, inspiratory, expiratory. Usually progress to severe respiratory distress, so it is more serious, more severe than unilateral vocal cord paralysis. It is associated with other abnormalities, for example, CNS abnormalities like Arnold-Chiari malformation. Very important to keep in mind, this can be associated with tumors or intracranial malignancy or intracranial mass. Or increased intracranial pressure. Very important. Diagnosis of vocal cord abnormalities, flexible laryngoscopy. If bilateral vocal cord paralysis, you need to get MRI of the head to rule out any intracranial abnormalities. Management, if it's traumatic, you should improve in 6 months. Bilateral vocal cord paralysis may need tracheostomy for breathing. Another cause of chronic stridor is laryngeal webs. Laryngeal webs is incomplete recanalization of laryngeal lumen during embryogenesis. Presents with weak cry and biphasic stridor, inspiratory, expiratory. Surgery can be curative if significant obstruction. Another cause of chronic stridor is laryngeal hemangioma. 50% accompanied by cutaneous hemangioma in the head and the neck. So if you have a child present with a stridor and you see hemangioma on the skin and the neck area, you should consider laryngoscope or investigation to find out if it's associated with laryngeal hemangioma. Clinical presentation is inspiratory stridor or biphasic stridor, inspiratory, expiratory. It may worsen as the hemangioma enlarges, similar to the cutaneous one, can become large with time, then start to shrink again. Diagnosis of laryngeal hemangioma is flexible bronchoscopy or direct examination. The treatment is propranolol for months to years. Laryngeal papilloma is another cause of chronic stridor. Papillomas are the most common cause of respiratory neoplasm in children. Transmission is a vertical transmission during birth from the birth canal. HPV virus, HPV 6 and 11 are the most commonly associated viruses. 60% are born to mother with genital wart or condyloma acuminata. Clinical presentation of laryngeal papillomas produces hoarseness of voice in infants. Most are solitary and occur in the larynx, but also can happen in other areas of respiratory tract. Treatment is surgical removal. Vocal nodules is another cause of chronic stridor. They are the most common cause of chronic hoarseness in children. The cause is voice abuse or misuse, like for example singers, and can be exacerbated by gastroesophageal reflux. The therapy is voice rest. Behavioral therapy may be effective, usually resolved by early teen. Surgery is rarely required. Subglottic stenosis. Subglottic stenosis produces inspiratory or biphasic stridor, inspiratory and expiratory. Congenital subglottic stenosis is rare and usually associated with other genetic syndromes. Acquired is the most common due to airway instrumentation or prolonged intubation, and this is more common. So the acquired cause of subglottic stenosis is more common than the congenital form. Tracheomalacia is another cause of chronic stridor. It produces expiratory wheezing secondary to airway cartilage flubbiness and also produces wheezing due to airway narrowing or collapse during expiration. Very important to know this association can be associated with esophageal atresia or tracheoesophageal fistula. Causes congenital or prolonged ventilation or mechanical ventilation in premature infants. Clinical presentation of tracheomalacia, expiratory wheezing, honking cough, apnea, cyanosis, and hypoxia in severe cases. Supine position and crying make it worse, and prone position make it better. So supine make it worse, and prone position make it better, similar to laryngomalacia. We'll start now a new subject, cough, which is very important and very common presentation in children. So cough receptors, you need to know that it is located throughout the respiratory tract, starting from the nose down to the lung. So airway mucosa all has cough receptors. So for example, patient with allergic rhinitis, they present with cough because of irritation of the nasal mucosa. Pharynx also, or the pharyngeal infection or infection of the pharynx can present with cough. Infection of the sinus or sinusitis can present with cough as well. Infection in the ear canal or external auditory canal or irritation of external auditory canal can produce cough. So cough is not only pneumonia. So you need to examine the patient. You need to take a good history in order for you to recognize and identify the source of cough. Family history is very important for the diagnosis of cough. Ask about if any family member is with eczema or atopy. Allergic rhinitis commonly associated with asthma as well. Ask if any family member is having asthma or using inhalers or nebulizers. Ask about if any family member with malabsorption or failure to thrive for possibility of cystic fibrosis. In the next few slides, we will review very important associations with cough will help you identify the cause or the diagnosis for cough. Staccato or paroxysmal cough comes suddenly or abruptly. Consider pertussis, cystic fibrosis, foreign body, chlamydia, or mycoplasma. If the cough followed by hope, consider pertussis or whooping cough. All day long but never during sleep. So the child keep coughing all day long, and when they sleep there is no cough. This is psychogenic or habit. Barking or brassy cough, consider viral croup, psychogenic, tracheomalacia, tracheitis, epiglottitis, laryngeal involvement. Follows exercise-induced asthma, accompanies with eating or drinking, consider aspiration, GERD, or gastroesophageal reflux disease, tracheoesophageal fistula, especially the H type. If the cough is associated with throat clearing, consider sinusitis or postnasal drip or habit. Productive infection or bronchiectasis. If the cough is at night, consider sinusitis or asthma. If the cough is associated with a change in season, consider asthma and allergic rhinitis. Immune suppressed patients, consider bacterial pneumonia, PCB, or tuberculosis, Mycobacterium avium intracellular, cytomegalovirus. If the patient of the cough associated with failure to thrive, so this is a very important combination, cough and failure to thrive, is cystic fibrosis until otherwise is proved. It is very important when a child presents with cough to ask about history of animal exposure. Birds can be associated with chlamydia psittacis or psittacosis. Rodents can be associated with Yersinia pestis or pneumonic plague and hantavirus. Rabbits associated with Francisella tularensis or tularemia. Sheep and cattle Q fever, pigeon histoplasmosis. Some states are commonly associated with certain diseases, like for example histoplasmosis, commonly seen in Mississippi, Missouri, Ohio, river valleys. Coccidioidomycosis in southwest states like Arizona and California. Blastomycosis in north and midwest states. Occupational cough. If the worker has cough during the work days and in off days there is no cough, this is suggestive of occupational cough. Here another few hints for the possible causes of cough. If the sputum is very purulent and the cough is chronic, consider bronchiectasis. If the sputum has high level of eosinophil, consider asthma. Combination of cough, Cough associated with anemia, consider hemosiderosis. Cough improved with trial of bronchodilator, consider asthma. Cough associated with ichthyosis or eczema, consider asthma. Cough associated with nasal polyp or failure to thrive of rectal prolapse, consider cystic fibrosis. This slide is very important. Any patient present with cough more than 6 weeks must be tested for cystic fibrosis, especially if there is nothing to explain why the patient is coughing and not responsive to treatment. Chronic cough more than 3 weeks, you need to take a good history, physical examination, imaging study, chest x-ray. If the chest x-ray cannot explain CT or even MRI to find out why the patient is coughing. It's not normal to keep coughing more than 3 weeks. It's not enough to change antibiotics or change medicine and the patient keep coughing. You need to find out why the patient is coughing. Screen for cystic fibrosis, do sweat chloride test, spirometry for asthma, CBC with differential, urinalysis for rare diseases, for example Wegener granulomatosis or Goodpasture syndrome. Digital clubbing or clubbing of digits, the other name is hypertrophic pulmonary osteodystrophy. You need to know this name, hypertrophic pulmonary osteodystrophy. Causes or common causes of clubbing of digits. The most common cause is cyanotic heart disease. The most common pulmonary cause is cystic fibrosis and or bronchiectasis. Biliary cirrhosis can cause that as well. Infective endocarditis, normal variant in family, so can be inherited in families with no other associated condition. Diagnosis of clubbing of digits. Of clubbing is a clinical diagnosis. You will see obliteration of the angle between proximal nail and the soft tissue. So this angle will be obliterated as you see here, and it should be like around 160, but here is 180 or more. So the angle will be lost. And if you face another digit, in normal person you will see a nice diamond shape, but in the cases of clubbing this angle will, or this diamond shape will be lost because of obliteration of the angle between the proximal nail and the soft tissue. Hemoptysis. Hemoptysis is coughing blood, but hematemesis is vomiting blood. The hemoptysis is usually bright red in color. Hematemesis is dark in color because of mix with acid in the stomach. Differential diagnosis of hemoptysis is upper airway. This is the most common presentation, especially in healthy children, which is nasopharyngeal bleeding. For example, epistaxis or nosebleed. This is very common. So if any child coughing blood or even vomiting blood, check the nose first. Gastrointestinal bleeding, bronchitis. Other causes or differential diagnosis of hemoptysis, bronchiectasis, airway trauma, foreign body, lung abscess, pneumonia, or tuberculosis. Mycetoma or fungal infection in the lung, idiopathic pulmonary hemosiderosis, arteriovenous malformation, pulmonary embolism. Pulmonary endometriosis, if the endometrial tissue abnormally located in the lung, should be considered in female presents with hemoptysis if no other causes are identified. Systemic lupus erythematosus if it is associated with vasculitis in the lung. Goodpasture syndrome and Wegener granulomatosis should be considered in any patient presents with cough and blood in urine. Churg-Strauss syndrome, they present in different stages. Stage 1, they present with asthma or recurrent bronchitis, allergic rhinitis, eosinophilia. They have also nasal polyps. They present also with recurrent fever and weight loss. These patients, if they have vasculitis in the lung, they may present with hemoptysis. Polyarteritis nodosa also may present with hemoptysis. Management of hemoptysis depends on the underlying cause. Generally, first thing to start with, examine the nose and the throat because this is usually the most common source in healthy children. Determine the pH of the emesis. If it's acidic and the emesis is dark, it is most likely is the stomach. If it's alkaline and the bright red blood, is most likely is the lung. Coagulation studies. Rule out infectious causes. Imaging studies, of course, it is important also to test the urine and do kidney function to make sure there is no renal involvement. Croup. The other name of croup is laryngotracheobronchitis. It's very important to remember this name. The most common cause is parainfluenza virus, but other viruses can cause that as well. For example, influenza virus, respiratory syncytial virus or RSV. The location is subglottic or below the vocal cord, which can cause subglottic narrowing and stridor or severe obstruction, airway obstruction. The age of presentation presents commonly in infants and young children between 3 months and 3 years of age. Clinical presentation of croup, usually they present with URI or upper respiratory tract infection like runny nose, congestion, with and without fever. The fever can be low grade and also can be high fever as well. Barking cough or brassy cough is very specific and unique and the characteristics of the croup. Inspiratory stridor or biphasic stridor, inspiratory and expiratory. Retraction, hypoxia, severe respiratory distress in severe cases. The child might prefer to sit or be held upright. Diagnosis, it's a clinical diagnosis. You do not need radiograph or chest x-ray or neck x-ray for the diagnosis of croup. Chest x-ray, you may see the steeple sign but can be absent as well, and the absence of a steeple sign do not rule out croup. The steeple sign can present to also normal person as a normal variant, so it's a clinical diagnosis again. Assessment of the severity of the croup. Mild croup, occasional barking cough, no stridor at rest, no or mild retraction. Moderate, frequent barking cough, stridor and retraction at rest with no or minimal agitation. Severe, frequent barking cough, persistent stridor and marked retraction, significant agitation and distress. So after that will be impending respiratory failure. The child will look lethargic, dusky, and depressed level of consciousness. Management of croup is mainly supportive, observation, reassuring the parents about the course of the disease and possible complications, adequate hydration, keep these children hydrated and well oxygenated. The dexamethasone or corticosteroid in general is very beneficial even in the cases of mild croup. Actually, it may be warranted to give it to any child with mild croup to decrease the chance of hospitalization. Dexamethasone, it has a long half-life between 36 hours and 54 hours. And a single dose can be given oral, IV, or intramuscular. Is very beneficial in the cases of mild croup. It decreases the laryngeal edema and the need for hospitalization. When it is safe to let the child go home, so safe dismiss after nebulized epinephrine from the ER or from your office. If there is no stridor at rest, normal air entry, normal color, normal level of consciousness, the child received 1 dose 0.6 milligram per kilo of dexamethasone orally, IM or IV. When you need to admit a child with croup to the hospital or even ICU, significant respiratory distress, stridor at rest, hypoxia or requiring oxygen, inability to feed or drink or looks dehydrated, requiring 2 or more nebulized racemic epinephrine treatment. This is very important to keep in mind. In cases of moderate to severe stridor or airway obstruction, oxygen and racemic epinephrine will be beneficial in this case. Remember that racemic epinephrine do not cause rebound obstruction, so can be safely used in the children with croup. Heliox or a mix of helium and oxygen. The oxygen percent here should not be less than 20%. The heliox, it has a low viscosity and low specific gravity, and it flows through the narrow airway easier than the oxygen by itself, so it can be used in the severe cases of croup. Endotracheal intubation should not be delayed until the patient becomes restless, cyanotic, or depressed consciousness. Use endotracheal tube smaller in size than the one regular for age, smaller 0.5 to 1 millimeter. Intubation usually more likely with bacterial tracheitis, epiglottitis than croup. It's rare in croup, but it's possible. Bacterial tracheitis, the most common cause is Staph aureus. Moraxella catarrhalis also can cause that, and Streptococcus. The mean age is about 4 years of age. The clinical presentation very similar to croup, brassy and barking cough, but in children with bacterial tracheitis, they look more toxic, they have high fever, and they do not respond to treatment of croup. Respiratory distress and stridor. Patients with bacterial tracheitis, they may lay flat. Epiglottitis, they sit down leaning forward, hyperextended neck or chin, taking this sniffing or tripod position. No drooling or dysphagia associated with bacterial tracheitis. Epiglottitis, they do have drooling and or dysphagia. Rapid progression, this is very important. You need to recognize the cases of bacterial tracheitis early, because purulent secretion may obstruct the airway, and frequently they require endotracheal intubation, especially in young children. Failure to respond to racemic epinephrine or corticosteroid, this is a red flag for you. So if you have a child with croup not responding to racemic epinephrine or corticosteroid, looks toxic, having high fever, you should consider bacterial tracheitis, not croup. Endotracheal intubation frequently needed in young children. 50 to 60% they do not need intubation, but still 50% requiring intubation. This is a very high percentage. So early treatment and early diagnosis is critical. X-ray are not needed for the diagnosis of bacterial tracheitis, but if it's done, it may show pseudomembrane detachment in the trachea. Humidification and careful suctioning of endotracheal tube is very important. You need to give anti-staph antibiotic to cover for staphylococcal infection. For example, nafcillin and vancomycin depending on the resistance in your area. Prognosis is excellent. Complication can happen like toxic shock, septic shock, pulmonary edema, ERDS, or subglottic stenosis. Common cold. I will point out just few cases here may present similar to common cold but is not common cold. The general consideration, the color of the nasal secretion. A lot of parents, they are concerned always about the color of the nasal secretion. Remember that a change in color or consistency does not indicate sinusitis or even bacterial infection. Green color nasal secretion it does not mean bacterial infection. Presence of polymorphonuclear leukocytes in the nasal secretion also does not indicate bacterial superinfection. So the color or the green color does not mean bacterial infection. Just to go by time in the cases of diagnosis of the sinusitis or severity. Bacterial culture only if group A streptococcus, bordetella pertussis or nasal diphtheria suspected. So you don't need to culture nasal secretion generally. Cough medicine or cough remedies is not helpful in most of the cases of common cold, especially in younger children. So cough medicine and cough remedies, it is not really the solution when any child presents with cough, especially younger children. You need to know the diagnosis and give the proper treatment. But cough medicine is not the solution. Also, you cannot really expect what side effects will happen because it's not well studied, especially in younger children. First generation antihistamine, for example, Benadryl or diphenhydramine. It reduces the rhinorrhea via anticholinergic effect. So it's helpful in the cases of rhinorrhea, but also you keep in consideration the side effects of diphenhydramine, especially in younger children. Second generation antihistamine is not helpful in reducing the rhinorrhea. Remember that second generation do not affect the rhinorrhea. Condition may mimic the common cold, allergic rhinitis. You will see the child here in this case prominent itching and sneezing. The symptom comes and goes abruptly. Nasal eosinophils are helpful. If you do nasal smear, you may see the eosinophil in the cases of allergic rhinitis. The nasal foreign body, you will see the children with nasal foreign body, they have unilateral foul smelling secretion and a bloody nasal discharge from one side. So when you have a unilateral foul smelling secretion from one side, you have to consider nasal foreign body and look for it. Cases may mistaken also with common cold is acute sinusitis. Sinusitis may present with fever or may present with fever, headache, facial pain, periorbital edema, and the rhinorrhea here, regardless the color, will be more than 14 days, but can be less than that but associated with high fever and headache, or in younger child will be poor feeding and loss of appetite or fussiness. Streptococcosis is a nasal discharge but infected with a streptococcal infection, and these children, they look sick and they may have fever, and the nasal secretion will cause crusting and excoriation of the nares or the skin around the nostrils. This is a 10 months old girl, presents in the month of January in the winter time with fever, runny nose, cough, poor feeding, tachypnea, respiratory distress, wheezing, low oxygen saturation, and positive RSV virus. The radiological finding in this case, you will see here the bilateral peribronchial fullness and coughing, and also air trapping in both sides and hyperinflation or hyperventilation of the lung. And the air trapping here is more on the left side than the right side. This is a classic presentation of RSV bronchiolitis. Acute bronchiolitis, viral bronchiolitis is the most common cause of the lower respiratory tract infection in 2 years and below. So it's more common in infants. RSV responsible for more than 50% of acute bronchiolitis. But we need to know when RSV negative bronchiolitis presents the possible causes of acute bronchiolitis. For example, human metapneumovirus is a common cause of RSV negative bronchiolitis. parainfluenza virus, adenovirus, influenza, rhinovirus, and mycoplasma. Risk factors for persistent wheezing or asthma in the future after RSV bronchiolitis or acute bronchiolitis. Maternal asthma is a risk factor. Maternal smoking, persistent rhinitis, eczema at less than 1 year of age. Clinical presentation of acute bronchiolitis in the beginning may present like any viral infection or common cold, runny nose, congestion, rhinorrhea, and cough, but the condition will progress to tachypnea, and this is the earliest and most sensitive vital sign change during the course of acute bronchiolitis. Nasal flaring, grunting, retractions, intercostal, supracostal, and subcostal retractions. In physical examination, crackles, wheezing, and referred upper airway noise because of significant nasal drainage and congestion. Apnea. Apnea may be the only presentation in young infants less than 2 months or former premature infants. So if you have an infant during the winter time or RSV season presents with only apnea, consider RSV cause of the apnea. It's very important to consider that. Also, acute bronchiolitis may progress from mild tachypnea to impending respiratory failure or ERDS. You need to know about the day of illness of acute bronchiolitis. Day of illness when the symptoms peak or become the worst, and this is around day 3 to 4 of illness. So you need to teach the parents about the possibility of worsening of symptoms in day 3 and 4 if you are managing as outpatient. And also it's very important for making decision about the admission or discharge in cases of acute bronchiolitis. Diagnosis of acute bronchiolitis based exclusively on the clinical presentation and physical examination. There is no need for radiologic studies or laboratory studies for the classic presentation of acute bronchiolitis. However, knowing the causative agent like RSV is very important for the rationale of the management and also for the prognosis and possible complication like recurrent wheezing or asthma. So if you will do the RSV study will be the study you will need for the classic presentation. So there is no need for X-ray, there is no need for blood work. Common radiological findings include hyperinflation from air trapping, peribronchial thickening because of lymphomonocytic infiltration, areas of atelectasis, and infiltrates. So remember, this is a virus and can cause viral pneumonia. Management. Assessment. The most important thing in the managing a case of acute bronchiolitis as outpatient or inpatient is respiratory rate, work of breathing, and the oxygen saturation. So if the patient is hypoxic, having respiratory distress, so this is the patient will require admission. Mainstay of treatment is supportive, oxygen if it's hypoxia, hydration, frequent nasal suctioning. Very important to know that the recommendation of American Academy of Pediatric about the use of bronchodilator and steroids, inhaled or systemic. You need to avoid routine treatment of bronchiolitis with bronchodilator, for example, albuterol, with inhaled or systemic steroids. But in the cases of history, if the parents have history of asthma or there is a strong family history of asthma, you may try the bronchodilator like albuterol, and if there is a response, you may continue the treatment with a bronchodilator. But definitely steroids, oral steroids is not necessary in the cases of bronchiolitis. Ribavirin or antiviral treatment is not required or is not routinely used in the cases of bronchiolitis. Prevention, the Synagis is a 15 milligram per kilo monoclonal antibodies injection. So this is very helpful in premature infants and high-risk infants, for example, with congenital heart disease. Hand washing is the best measure to prevent nosocomial infection of acute bronchiolitis because of RSV. RSV, remember, is transmitted as contact, is not airborne. So RSV is contact, is not airborne. So hand washing is the key, not the mask. Asthma is a very important topic. Despite advances in medical management of asthma, the childhood asthma continue to be a leading cause in the emergency department visit, hospitalization, and missing school days. Asthma is more common in boys, and you have to know that once the asthma is diagnosed, you have to assess the severity of the asthma, and we'll learn that in the next few slides. Categories of asthma: intermittent asthma, mild persistent, moderate persistent, and severe persistent asthma. We will learn more details in the next few slides. This is a 7-year-old boy who had asthma since 2 years of age. Presents with increasing frequent cough. His symptoms occurs daily. They get worse when he is playing football. They wake him up at night 3 to 4 times per week. What is the best description of the severity of his asthma? So we have the asthma on daily basis, worse with exercise, and occurs at night 3 to 4 times per week. 3 to 4 times per week. So what is the best description of the severity of this asthma? Intermittent, mild persistent, moderate persistent, severe persistent, or asthma variant? I will answer these questions after the next slide. Classification of asthma and initiating treatment. In this diagram, you will learn different classes of asthma and the best treatment for each class. The first one is intermittent asthma. The child will have 2 days or less symptoms per week, and less than 2 nights per month. So less than 2 days or less per week, and less than 2 nights per month. The pulmonary function test here is normal and no limitation with activity. The best treatment for this class is short-acting beta-2 agonist as needed. No corticosteroid is necessary, either inhaled or oral, so no steroids in this case. So just a short-acting beta-2 agonist as needed, for example, albuterol. Mild persistent asthma, the child will have symptoms more than 2 days per week and more than 2 nights per month. The pulmonary function test here is more than 80%, FEV1 to FEVC ratio more than 80%, and minor activity limitation. The best treatment for this class is low dose of inhaled corticosteroid. You need to teach the parent that this medicine to be given every day on daily basis, not as needed. If they are coughing, they use the rescue inhaler with short-acting beta-2 agonist as needed for cough. But if the child require to use the short-acting beta-2 agonist many times, or consuming a lot of albuterol, you know that his symptom is not controlled and he need to go a step up or to go to the next step to control his symptom. The next one is moderate persistent asthma. The symptoms, daily symptoms, and more than 1 night per week. And the pulmonary function test here is worse, is FEV1 60 to 80% and FEV1 to FEVC ratio 75 to 80%. Some limitation with activities. There is some limitation with activity. The best treatment here is higher dose of inhaled corticosteroid or medium dose inhaled corticosteroid, and consider short course of oral corticosteroid, especially if the child having acute asthma exacerbation. Severe persistent asthma, here the child will have the symptom all days and most of the nights, and the pulmonary function test will show FEV1 less than 60%, this is significant, and FEV1 to FEVC ratio less than 75%, this is also very significant, and there is extreme limitation with activity. The treatment here is the same as step 3. This is step 1, step 2, step 3. So you give this treatment to the child with severe persistent asthma. If it's not working, you use medium dose inhaled corticosteroid plus long-acting beta-2 agonist, and consider short course of oral corticosteroid 5 to 10 days in order to control the symptom. Remember, when you have a child with persistent asthma, you need to use inhaled corticosteroid all the time on daily basis, not as needed. This will help to prevent the acute asthma attack and hospital or frequent hospitalization or visits to the ER, or even admission to the ICU or the PICU. This is the answer for the previous case. This is a 7-year-old boy who had asthma since 2 years of age, presents with increasing frequent cough. His symptoms occurs daily, so this is a key word, and worse when he's playing, worse with exercise, and the symptoms wake him up at night 3 to 4 times per week, so is more than 1 night per week. So daily symptom more than 1 time per week. This is consistent with moderate persistent asthma. Associated risk factors with asthma: parental history of asthma. It is very important to ask for any child presents with cough if there is any parental history of asthma or family history of asthma, atopic dermatitis or eczema, sensitization to aeroallergens, for example allergy to pollens, food allergies, more than 4% eosinophilia. The higher the eosinophil level, the higher the risk of asthma. Most common trigger for asthma is respiratory viral infection, especially rhinovirus. This is the most common trigger, URIs. Allergens, airway irritants, for example, smoking, air pollution, exercise-induced asthma, medication, for example, non-steroidal anti-inflammatory medication, ibuprofen, for example, beta blockers also can trigger asthma. Clinical presentation of asthma: wheezing. Wheezing is very significant for asthma. A musical high-pitched whistling sound produced by airflow turbulence. But absence of wheezing does not rule out asthma. Sometimes the kids with asthma, they present only with cough and no wheezing. Usually the cough is non-productive and non-paroxysmal, and the cough may be present with or without wheezing, so keep that in mind. Cough at night or with exercise or exercise-induced asthma. Chest tightness or chest pain can be a reason for a visit to the office or the ER. The parents, they may be thinking it's cardiac or the heart causing the chest pain. But children with asthma, they may present with the chest pain with or without cough, with or without wheezing. Remember that a chest pain caused by cardiac causes is rare in children. It is more common to be musculoskeletal or asthma than cardiac causes. Shortness of breath, sputum production. Infants and young children suffering a severe episode of asthma may present with breathlessness during rest, not interested in feeding or poor feeding, sitting upright. If able to talk, they use word, not sentence, and usually they are agitated. Tachypnea is a very important sign indicating the severity of the asthma. Tachycardia, accessory muscle use or retractions. Wheezing can be heard but also can be absent, especially when the asthma is more severe. So absence of wheezing does not make you feel comfort that the child is better, can be even worse. Pulsus paradoxus, which is a drop in the systolic blood pressure during inspiration, should be less than 10. If the pulsus paradoxus or the drop of blood pressure or the systolic blood pressure more than 20 millimeter of mercury, this is significant. Oxyhemoglobin saturation can be less than 91, and the lower, of course, the worse, and the more requirement for oxygen. If the asthma left untreated or acute asthma exacerbation left untreated or untreated properly can progress to status asthmaticus. So in the kids with the status asthmaticus, they present like asthma but more severe. So they have more respiratory distress, which is a paradoxical thoraco-abdominal movement. You will see them using their abdomen to breathe, and they look very tired. Severe airway obstruction, wheezing may be absent in this case. Bradycardia instead of tachycardia, this means severe hypoxemia. This is a very bad sign. Pulsus paradoxus may disappear, suggest respiratory muscle fatigue and impending respiratory failure. Kids with status asthmaticus, when they do not receive the appropriate treatment on time, so they may become confused and drowsy. Adolescents may not show these symptoms until they are in frank respiratory failure. Signs of impending respiratory failure: tachypnea. Of course, the higher the respiratory rate, the worse. Retractions, dyspnea. Pulsus paradoxus more than 20 millimeter of mercury. Normal or rising CO2 and arterial blood gas. Normally, when a child is hyperventilating, usually the CO2 should be low. When you see it is normal or rising, this is a bad sign. Anxiety, tachycardia, or bradycardia in severe cases of hypoxemia, drowsiness and confusion. So do not let a child with asthma go to this sign. So act early and treat early. Management of status asthmaticus, oxygen monitoring and therapy. Most of the kids with status asthmaticus, they are requiring oxygen because of respiratory distress and tachypnea. Hydration is very important to keep them well hydrated with IV fluid. Beta-2 agonist is the mainstay of treatment and can be given, so you can give the albuterol either continuous nib or intermittent therapy. Ipratropium is very helpful to be combined with albuterol in the cases of status asthmaticus. IV steroid is a strong anti-inflammatory, and this is what will help to resolve the case of the status asthmaticus and resolve all the inflammation inside the lung. So don't act early and give the steroids early. It works for within 4 to 6 hours. So a steroid treatment should not be delayed in the cases of status asthmaticus. Nebulized steroids is helpful as well. Magnesium sulfate, if the above treatment is not working and the child keep getting worse, magnesium sulfate is very helpful in the cases of severe status asthmaticus. Clinical presentation in the cases of acute asthma exacerbation, and this you can have that in your office. Dyspnea at rest, peak flow is less than 40%, retractions, failure to respond to the initial treatment. Management of acute asthma exacerbation. Beta-2 agonist or albuterol should be given more frequent in the first few days until the wheezing disappears and the child look better and feel more comfort. Inhaled anticholinergic ipratropium is helpful as well. Oxygen if is necessary. A systemic steroid should be given early in the treatment. It will work from 4 to 6 hours, and it is very helpful to decrease the inflammation inside the lung and resolve the acute asthma attack. Home administration of short-acting beta-2 agonist or albuterol and oral steroids. The patient should be advised to continue using the albuterol for at least a minimum 5 days and short follow-up afterward. Oral steroids 3 to 10 days is very important to resolve the inflammation inside the lung. No antibiotic is necessary for atelectasis. Avoid giving antibiotic in cases of asthma unless if you strongly believe that there is an associated pneumonia like fever and infiltration is significant in the X-ray. But atelectasis do not require antibiotic. Diagnosis of asthma is a clinical diagnosis, do not require imaging studies or certain laboratories. Pulmonary function test is very helpful in assessing the asthma and the severity of the asthma and response to treatment. So in spirometry, we'll see the obstructive pattern as we discussed previously in the beginning of this lecture. Exercise-induced asthma, you need exercise challenge in order to diagnose, because normally the patient will not wheeze if no exercise. So you will do a treadmill or bicycle to trigger the asthma. You will do baseline spirometry followed by exercise. Then you do again a spirometry afterward, and you will see the drop in the airflow rates if they have exercise-induced bronchospasm. Chest X-ray or radiography is not necessary in the cases of asthma, but if it's done, you may see hyperinflation, increased bronchial marking, evidence of parenchymal disease, atelectasis, or even pneumonia. If there is underlying cause of the wheezing, you may see congenital anomalies or foreign body. Foreign body can present with wheezing and mistreated as asthma. Allergy skin testing is very important for detection of the allergen or the triggers of asthma. And by avoiding this allergen, this may resolve the cases of asthma in many cases. Skin testing is a reliable test for detection of the allergen or the type of allergy. In vitro allergy testing or blood testing for allergy now is getting more popular, which is the ELISA test. Exercise-induced asthma. Poorly controlled asthma may worsen with exercise. This doesn't mean that the exercise makes the asthma worse. Actually, exercise makes the asthma better, but if you control it very well. So well-controlled asthma actually may get better or improve with doing exercise, but poorly controlled asthma may worsen with exercise. Asthma with exercise can be the only presentation. So some children, they have exercise-induced bronchospasm only. So asthma with exercise only, and in between they look normal and there is no wheezing, no shortness of breath, or no symptom. Symptoms may start during or after exercise. Symptoms may last about 90 minutes or even longer all day long. Management of exercise-induced asthma. Warm-up exercise before vigorous exercise. So warm-up technique is very important. Pre-medication or pre-medicate the patient with short-acting beta-2 agonist albuterol 15 minutes before exercise. So you give 1 or 2 puffs using the MDI or meter dose inhaler 15 minutes before exercise, and this is the classic treatment of exercise-induced bronchospasm. If this treatment is not sufficient to alleviate the asthma symptom, or the patient need more than 1 treatment per day, you need to add inhaled corticosteroids or leukotriene inhibitor, for example montelukast or Singulair. General management of asthma assessment and monitoring. You need to assess and classify how severe is the asthma by asking about day and night symptoms and symptoms associated with exercise. Self-management education. You need to teach the parents how to use the meter dose inhaler or dry powder inhaler, aero chamber, or even nebulizer. You need to see the child, how the child is using, and ensuring the correct delivery of the medicine to the lung. Medication use and adherence. You need to teach them which medicine is used as needed, which medicine need to be used all the time. So this is very important. Control environmental factors if there is any allergens and other associated medical condition. Asthma medication. Beta-2 agonist, it relieves the constriction or bronchospasm by relaxation of smooth muscle in the bronchi and bronchioles. Frequent use of beta-2 agonist indicates poor asthma control. Is not a good sign. If the patient asking you for refills on the albuterol and not the inhaled corticosteroid, you know that this patient is not controlled and is not using the medicine correctly. So using inhaled corticosteroid to control the asthma is more safe than using beta-2 agonist all the time and the patient continue to be wheezing. Short-acting beta-2 agonist albuterol, the onset of action is 15 minutes and the duration is 3 to 4 hours. So the onset of action of albuterol or short-acting beta-2 agonist 15 minutes and the duration is 3 to 4 hours. Long-acting beta-2 agonist, for example salmeterol or formoterol, the effect can last up to 12 hours. This is an excellent medication for the patient with severe persistent asthma, but you cannot use it alone. It has to be used with steroids. If you use it alone, this puts the patient at risk for sudden death related to the asthma and can cause life-threatening asthma exacerbation. Know the potential side effects or adverse effects of beta-2 agonist. Can cause agitation, irritability and tremors, insomnia, tachycardia and arrhythmia, hypokalemia. Patients with diabetes mellitus are at high risk for hypoglycemia because it will mask the symptoms of hypoglycemia. Inhaled corticosteroid. This is very important. The most commonly prescribed maintenance therapy for asthma. So this is the mainstay for treatment of persistent asthma in general. They effectively decrease the airway inflammation, decrease the bronchial hypersensitivity, relieve asthma symptoms, improve lung function. Inhaled corticosteroid. You need to know the side effects. Parents will always ask about the growth and the effect of inhaled corticosteroid on the growth of the child and the height. So very important to know. High dose of inhaled corticosteroid may slow the growth in the first year, but they catch up during their growth spurt. Poorly controlled asthma actually may suppress the growth more than the regular use of inhaled steroid. So poor controlled asthma may suppress the growth more than regular use of inhaled steroid. And also studies showed that inhaled corticosteroid may affect the growth only in the first year. And long-term study also suggests that merely delay in growth and final adult height is not changed with using inhaled corticosteroid, and they catch up during their growth spurt. Oral thrush is a side effect of inhaled corticosteroid, but to prevent that, rinse the mouth after taking the medication with water. Using a spacer may help also. Osteoporosis is a side effect of high dose of inhaled corticosteroid, is a possible side effect, and or oral corticosteroid. So how to prevent that? This can be minimized by doing exercise, adequate calcium intake, and vitamin D. Leukotriene antagonist or inhibitors, montelukast or singular, it blocks the inflammatory pathway that are active in the disease. It usually well tolerated, frequently used as add-on therapy in addition to inhaled corticosteroid. May benefit patients with allergic rhinitis, recurrent asthma because of viral infection, and exercise-induced bronchospasm or asthma. Children at significant risk of having asthma in the future or later in life, less than 3 years of age if the asthma started before 3 years of age, 3 or more episodes of wheezing per year, eczema or parental eczema, allergic rhinitis, wheezing unrelated to colds, blood eosinophil count more than 4%. Medication delivery devices. Learn about these devices before you prescribe it to your patient. First one is MDI or meter dose inhaler. It's a chamber and it has hydrofluoroalkane propellant. The medicine here is under pressure and will come in a form of a spray. and you advise the patient to exhale, then place the mouth around the mouthpiece, then take a deep breath while at the same time you are releasing the medicine. Then ask the patient to hold it as long as possible. Meter dose inhaler. Dry powder inhaler, it has the medicine in form of powder, and when you load it, the powder will be ready to be inhaled. So the powder will not come out by itself. The patient need to place the mouth around this area and take a deep breath and hold it as long as possible in order for the powder to come out from this device down to the lung. Dry powder inhaler or DPI approved for children 4 years and above. Jet nebulizer is an air compressor, where the air comes out here through a chamber where is the liquid medicine here, the albuterol or the steroid, and it will be nebulized through the mask. The medicine here or the treatment may require 5 to 15 minutes to be delivered through this machine. So using this machine is not practical. So if you have the choice between the MDI and the jet nebulizer, of course MDI is quick, is easy to carry, is practical, and you can take it anywhere. The jet nebulizer is not practical to take it away from home. It requires electricity, it may break. So it's useful when the children are very sick, they are cognitively impaired, or they cannot use these devices. Know that 4 puffs of albuterol with MDI equal to 2.5 milligram nebulized albuterol with the jet nebulizer. So this one will take less than a minute to deliver this medicine. This one will take a very long time, 15 minutes, in order to deliver this medicine. So this is more practical. The aero chamber is for school-aged children or younger children. They cannot use the MDI directly. So you place the MDI in this side. The child will place his mouth around this mouthpiece, and you release the medicine, and you ask the child to take a deep breath and hold it for about 10 seconds. And if the child cannot cooperate, you use the mask. So if you place the mask here and you release the medicine, you just ask the child or to encourage the child to continue breathing for 10 seconds. This way the medicine will come out to or go down to the child's lung. So know this method of delivery is very important. This is a chest x-ray of a 5-year-old boy who presents with high fever, cough, tachypnea, grunting, crackles on the right side of the chest. As you see here in the chest x-ray, there is a consolidation and infiltration in the right middle lobe, and also you can see it here on the lateral view, and this is a classic presentation of pneumonia or right middle lobe pneumonia. Causes of pneumonia: chlamydia trachomatis, interstitial infiltrates, you will see in chest radiograph, and you will see it bilateral. Respiratory syncytial virus can cause bronchiolitis or pneumonia, viral pneumonia. Parainfluenza also can cause bronchiolitis or viral pneumonia. Streptococcus pneumonia, of course, can cause bacterial pneumonia. Also Bordetella pertussis can cause tracheobronchitis with severe paroxysm and usually with no fever and no wheezing. Pneumonia may occur secondary to aspiration. Mycoplasma pneumonia or walking pneumonia increase the incidence in children approaching school age. So school-aged children very common to have this type of pneumonia. Pneumonia by geographic tropism: histoplasmosis in Ohio, Mississippi River valleys and the Caribbean; coccidioidomycosis, California, Arizona, and New Mexico; blastomycosis is Ohio, Mississippi River valleys, Great Salt Lake states; Legionella in infected water worldwide; severe acute respiratory syndrome is Asia; and avian influenza, Southeast Asia. Pneumonia via animal vectors: tularemia via rabbits and ticks; psittacosis, birds, especially parakeet; Q fever, sheep, cow, and goats. Pneumonia associated with exanthem, varicella, and measles. Clinical presentation of pneumonia: fever. If the child presents with fever and cough, this is very helpful in the diagnosis. Most of the children with fever and cough, actually they do not have pneumonia. Also, absence of fever or absence of cough do not rule out pneumonia. It has to be in your differential, especially if the child is tachypneic or even present with the chest pain or even abdominal pain. It has to be in your differential. Tachypnea, respiratory distress, retractions, and wheezing. Nasal flaring, grunting. Grunting is very important to keep in mind. It may be a sign of pneumonia as well as impending respiratory failure as the child is trying to keep the lung open because of atelectasis. Apnea and abdominal pain, keep that also in your differential for abdominal pain. Pneumonia can present with abdominal pain. Tachypnea is the most sensitive and specific sign of pneumonia. More than 50 breaths per minute at 2 to 12 months of age is tachypnea. More than 40 breaths per minute at 1 to 5 years of age is tachypnea. More than 20 breaths per minute for those older than 5 years also is tachypnea. Keep in mind if the child is have fever, just subtract 10 for the respiratory rate. In physical examination, you may find dullness to percussion, crackles, decreased breath sounds, or bronchial breath. Know that bacterial pneumonia is very unlikely in cases of absence of fever, absence of tachypnea, no increased work of breathing, normal auscultation. So this makes the bacterial pneumonia is very unlikely. Diagnosis of pneumonia is a clinical diagnosis. Do not need X-ray or lab work in order to diagnose typical cases of pneumonia. Blood culture is helpful if it's positive. 10% of the time the organism are recovered. A study of a choice after a chest X-ray. So this is the study of a choice for pneumonia after a chest X-ray. CBC may be helpful. ASR and CRP tuberculin test if the tuberculosis is considered. A chest X-ray for pneumonia. Know that a chest X-ray for pneumonia will not change the clinical management for most of the children managed as outpatient. Also, afebrile children normally do not require a chest radiography. When to order a chest X-ray in cases of pneumonia? If complicated pneumonia is considered, fever is prolonged or any worsening, like for example considering empyema for example, no obvious source of infection, especially in very young infant. A chest X-ray always lag the clinical response, so you do not need to order a chest X-ray to see if the patient improved or not, because you may see the consolidation is still there but the patient clinically improved. Management of pneumonia as outpatient. For uncomplicated cases of pneumonia, high dose of amoxicillin 80 to 90 mg per kilo per day is recommended. The same dose you are using for acute otitis media. So a high dose of amoxicillin 80 to 90 mg per kilo per day. If resistance, augmentin or oral cefuroxime, which is a second generation of cephalosporin, as outpatient. School-aged children or older than 5 years, mycoplasma is a common cause of pneumonia at this age, and the best medication for that is azithromycin. When you should consider hospitalization for a child with pneumonia: suspected sepsis, toxic appearing, which can be a sign of empyema or severe pneumonia, hypoxemia, requiring oxygen, inability to drink, severe dehydration, unresponsive to outpatient therapy or getting worse. Inpatient management of pneumonia: administer IV fluid, oxygen and antibiotics. Consider blood culture, chemistry profiles, complete blood count and the chest radiography. If inpatient, the antibiotic you will recommend it to use is cefuroxime, second generation cephalosporin, or third generation cephalosporin, ceftriaxone or cefotaxime. In adolescent, levofloxacin, gefloxacin, moxifloxacin may be used in the cases of atypical pneumonia. If staph is considered, consider vancomycin or clindamycin. Uncomplicated cases of pneumonia respond to antibiotics within 48 to 96 hours, so the child should improve as he or she taking the antibiotics. Plan if no response or persistent pneumonia, or the pneumonia you are treating is getting worse. Plan to repeat the chest X-ray or do the chest X-ray if it was not done. Consider the following in your differential: empyema, tuberculosis, foreign body, bronchial obstruction, cystic fibrosis, pulmonary sequestration, and aspiration. Consider these if the child is not responsive to your treatment or getting worse at any time. This is a 15-month-old girl was admitted to the hospital because of pneumonia and respiratory distress. On the third day of admission, she became toxic, grunting, tachypnic, tachycardic, requiring more oxygen. Lung sound is less audible on the right lung field. As you see here in this X-ray, you will see right pleural effusion and blunt or absence of the costophrenic angle, and also here you will see fluid in the horizontal fissure and also shift of the mediastinum to the left side. This is a classic presentation of pleural effusion developed after case of bacterial pneumonia, and most likely is empyema. Pleural effusion. Effusion considered if more than 10 ml of fluid in the thoracic cavity. It is due to excessive filtration or defective absorption. The possible causes: infection, chyle or lymph, fluid, blood, malignancy, drug exposures. In neonatal period, know that the chylothorax is the most frequent type of pleural effusion. Transudate and exudate. Transudate is usually low in protein and LDH. The exudate, you need at least one of these criteria to consider exudate. Pleural fluid to serum protein ratio is 0.5 or more. Pleural fluid to serum lactate dehydrogenase or LDH ratio is more than 0.6. The level of LDH in the pleural fluid is two-thirds of the upper limit of the reference range. Clinical presentation of pleural effusion should be suspected in any child with worsening pneumonia, respiratory distress, tachypnea, chest pain and cough, decrease or absent breath sound in the affected site, mid-line shift, pleural rub if a smaller collection of fluid, egophony, dullness to percussion. Diagnosis: at chest radiography, you will see opacification of the thorax, blunt of the costophrenic angle. Ultrasound can determine the presence or absence of loculation. CT scan define the pulmonary and the fluid characteristics for complicated effusion and empyemas. Management of pleural effusion: thoracentesis, oxygen for hypoxemia, antibiotics, and consultation with experts as needed. This is a 12-month-old boy with underlying chronic lung disease. Suddenly become unresponsive, breath sound is not audible on the right side of the lung, trachea shifted to the left, and 60% oxygen saturation. So the oxygen saturation deteriorated down to 60%. This is a classic presentation of tension pneumothorax or right side tension pneumothorax. You do not need a chest x-ray to diagnose this case. So this case has to be treated immediately before a chest x-ray or before ordering chest x-ray. Anyhow, the chest x-ray here shows a right-sided pneumothorax with depression of the right hemidiaphragm, which is a reliable sign in the case of tension pneumothorax, and shift of the mediastinum to the left. And also here you will see a continuous diaphragm sign of pneumoperitoneum. So this is a classic presentation of tension pneumothorax, should be treated immediately with thoracentesis with no wait for imaging study. Causes of pneumothorax: spontaneous pneumothorax, a primary, occurs without trauma or underlying cause, more common in tall, thin male, and they thought to be because of subpleural blip. Smoking also is a cause. A family history is positive in many patients. Secondary pneumothorax: underlying lung disease, trauma, loud music because of air pressure. Clinical presentation of pneumothorax: usually the onset is abrupt. Severity of the symptom depends on the lung collapse. Tension pneumothorax: the symptoms appear suddenly and the child become hypoxic, dyspneic, cyanotic, and not even responsive. Shift of the mediastinum to the opposite side. This will depend on the amount of the pneumothorax or the volume of the pneumothorax. Management of pneumothorax: small pneumothorax, oxygen is helpful. Observation: less than 5% may resolve spontaneously with no treatment. Chest tube drainage if more than 5% pneumothorax or associated with collapse, or if pneumothorax is recurrent or under tension. Aspiration syndrome: very important information about aspiration syndrome. Any foreign substance inhaled into the lung can cause aspiration syndrome. Most common is gastric aspirate. Small volume more than 0.8 ml per kilo or pH less than 2.5 can cause hemorrhagic pneumonitis or atelectasis. Large volume of aspirate can cause pulmonary edema. The symptoms may appear minutes to hours after aspiration event. Radiographic change may take time to appear, 1 to 2 days, unless large volume was aspirated. Hydrocarbon may be ingested accidentally by the children and can cause aspiration syndrome. Examples of hydrocarbon: gasoline, kerosene, mineral spirits, benzene, toluene, and motor oil. Management of aspiration syndrome is supportive. Oxygen if required. Immediate suctioning of the airway. Do not attempt to neutralize the acid. So suction the airway, ensure the child is breathing fine, and do not neutralize the acid. Do chest x-ray. Intubation and mechanical ventilation in severe cases. Prophylactic antibiotic is not recommended, or even steroid not recommended in the cases of aspiration syndrome, even with fever. Management of aspiration syndrome: asymptomatic and normal chest x-ray observation. So asymptomatic and normal chest x-ray observation 4 to 6 hours in the ER, in the hospital, or in your office. Asymptomatic and abnormal chest x-ray should be admitted if close follow-up is uncertain. Most dangerous is hydrocarbon. Initially the child may look fine, but the symptom or the child may deteriorate very quickly. So close observation is very important. Gastric emptying is contraindicated in cases of hydrocarbon aspiration. Very important. Foreign body aspiration is very important to keep in your differential for any child present with persistent cough. Nuts, especially peanuts, is 1/3 of the cases. Other foreign body can be aspirated: hot dog, grape, nuts, candies. The most common age is less than 3 years of age. Hot dog actually can cause sudden death. It's very dangerous to give to children, to very young children. Clinical presentation: initial event, if it was witnessed by the parents, you will see a paroxysm of coughing, choking, and gagging. Then the child may go through the asymptomatic interval, and this is the misleading time for all the clinician and everybody, because the child doesn't have any symptom. The child with foreign body aspiration may present with recurrent wheezing or chronic cough, and actually may be treated as a case of asthma. But your key here that the child will present again with recurrent wheezing despite the appropriate treatment. So you should consider foreign body in this case. Stridor, dyspnea, cyanosis, retraction. The child may have diminished breath sounds on one side. The child also may have normal breath sounds on both sides. So normal lung exam do not rule out foreign body aspiration. Very important to know about foreign body aspiration. Positive history must never be ignored. If the mom or the dad or anyone witnessed the child aspirating a foreign body, means there is a foreign body, even if there is no symptom. Simply the child can be during the asymptomatic stage, so you cannot ignore this history, means that you must investigate. Negative history may be misleading. If the child was not witnessed and presenting with persistent cough, you should consider the foreign body aspiration in your differential. A choking or coughing episode accompanied by wheezing are highly suggestive of foreign body, especially if presents suddenly. 58% of the foreign body, they are large or they are located in the right bronchus. However, it can occur also in the left bronchus or the left side of the lung. Diagnosis: a chest x-ray and neck x-ray. You cannot just do chest x-ray, you have to do both, because you may miss foreign body in the neck. Chest x-ray is negative in 10 to 30% of the cases, simply because of radiolucent foreign body. So if the chest x-ray is negative, this does not rule out foreign body aspiration. Patients suspected of having airway foreign bodies should undergo chest radiography. The lack of radiological finding never can be used to exclude airway foreign body. So if you highly suspect a foreign body, you will go for CT or bronchoscopy directly. Common radiological finding in the cases of foreign body aspiration. Normal finding: expect when you order a chest x-ray for foreign body aspiration, the x-ray may come normal and the foreign body is still there. Hyperinflation or air trapping: if the foreign body causing partial obstruction, the foreign body will act like a valve and will cause air trapping, and the mediastinum may shift in this case to the opposite side. Atelectasis or lobar collapse if is causing obstruction or complete obstruction of a main bronchus or bronchiole. Mediastinal shift depending of his atelectasis or hyperinflation. Atelectasis will be the shift to the same side, and hyperinflation, the shift will be to the opposite side. Infiltrates, pneumonia or abscess you may see in a chest x-ray. Inspiratory, expiratory or decubitus film may be helpful in detection of the foreign body. Management of foreign body aspiration: the treatment of choice, prompt removal with rigid bronchoscopy. If you highly suspect foreign body aspiration, you go ahead and treat with rigid bronchoscopy, even with normal chest x-ray. Bronchoscopy can be deferred until proper hydration and emptying of the stomach. Complication of retained foreign body: bronchiectasis, hemoptysis, and lung abscess. Pulmonary abscess: it's a cystic area due to necrotic lung tissue. It's at least 2 cm in diameter. Primary causes aspiration or infection. Secondary causes dysphagia, developmental delays, poor airway protective reflexes, poor airway clearance from neuromuscular weakness. Bacteria can cause that. Aerobic and anaerobic are the most common cause of pulmonary abscess. This is very important when you are considering antibiotics. You need to cover for anaerobe. Clinical presentation: fever, cough, sputum production, hemoptysis, vomiting, tachypnea, chest pain, weight loss. Diagnosis of pulmonary abscess at chest X-ray. You will see air fluid level, and in the CT scan will give you a better anatomic definition. Management: clindamycin. Clindamycin covers for anaerobe, so this is the best antibiotic you start with until you have the culture and sensitivity is available. So the treatment with IV antibiotic for 2 to 3 weeks and followed by oral course for 4 to 6 weeks at least. The prognosis is excellent. This is an X-ray and CT scan of a 4 weeks old boy present with persistent dry cough. So here in the X-ray you will see a mass in the left lung and does not silhouette the left border of the heart. Here you will see the cell sign of the healthy thymus in this infant. In the CT scan, the dense uniformly mass here is apparent in the left side of the lung, and this consistent with pulmonary extralobar sequestration. Pulmonary sequestration. It's a congenital pulmonary malformation. It could be cystic or solid. This tissue is non-functioning, so there is no gas exchange in this tissue. Does not communicate with the tracheobronchial tree, so it's isolated. It has anomalous systemic blood supply instead of pulmonary arterial blood supply. Pulmonary sequestration. In this table, we'll learn the difference between the extralobar sequestration and intralobar pulmonary sequestration. So the extralobar is more common, so extra is more common, intralobar is rare. The extralobar is has its own separate pleural sac, so is covered in visceral and parietal pleura separately from the lung. The intralobar is within the visceral pleura from the name. Intralobar within the visceral pleura of the normal lung. Both of them, they are not functioning tissue, no gas exchange, no communication with the tracheobronchial tree. Both of them, they are more common on the left side. For the extralobar is associated with extra anomalies, remember that. So associated with diaphragmatic hernia and colonic duplication. Associated anomalies in the intralobar pulmonary type sequestration is rare. Usually the extralobar presents early in life, and the intralobar presents during childhood and adolescence. Many patients with extralobar pulmonary sequestration presents in infancy with respiratory distress and persistent cough. The patients with intralobar may begin symptom early in life with recurrent pneumonias. Clinical presentation of pulmonary sequestration: chronic cough, recurrent pneumonia, and respiratory distress. So keep this in your differential for any child presents with recurrent pneumonia or persistent cough. Diagnosis of pulmonary sequestration: chest radiography, CT scan with contrast will confirm the diagnosis. Treatment is often surgical removal, and surgical removal is necessary because the sequestrations or retained sequestration may become malignant. This is a CT scan of a 6-year-old boy who presents with recurrent pneumonia. In this CT scan, you will see on the right side here is a large, smoothly marginated, hypodense mass, homogeneous, originating from the subcarinal region. The final diagnosis of this case is bronchogenic cyst. Very important to be familiar how the bronchogenic cyst look at the chest X-ray. Also, bronchogenic cyst can be found accidentally or incidentally on a chest X-ray done for other reason. So in this X-ray, there is a spherical mass or paraspinal mass on the left side here, and the characteristics of bronchogenic cyst usually is sharply demarcated spherical mass. So look for this word, sharply demarcated spherical mass of variable size, most commonly located in the mediastinum in the middle around the carina. And when the cyst is infected or it has secretion, it may show as a solid mass or with air fluid level. Know about the bronchogenic cyst: it arises from abnormal budding of the tracheal diverticulum. Patient may become symptomatic if the cyst enlarge or become infected, and the symptom, it depends where the cyst and the site of compression. Clinical presentation can be asymptomatic and can be found accidentally or incidentally in a chest x-ray done for other reason. Symptom varied by the location of the cyst. Airway or esophageal compression. So for esophagus will give you dysphagia. For the airway may present with cough or dyspnea. May cause superior vena cava syndrome. May present with pneumothorax or recurrent pneumonia. Diagnosis, prenatal diagnosis with ultrasound is possible. Chest x-ray can show the cyst. CT or MRI demonstrate the anatomy. Sharply demarcated spherical mass of variable size. Remember this word. Commonly located in the middle mediastinum around the carina. Treatment is surgical removal. Congenital lobar emphysema is a very rare respiratory disorder. The air can enter the lung but cannot escape. This is the problem in this condition. And this can cause overinflation in one or more lobes of the lung and subsequent compression or compressive changes in the rest of the lung. Usually presents in the newborn with respiratory distress. The treatment is usually surgical, but some cases may resolve with no surgery. Another rare congenital lung disease is congenital cystic adenomatoid malformation. This is a dysplastic lung tissue and presents in the newborn with respiratory distress. In older children will present with recurrent infection or pneumonia, hemoptysis, dyspnea, or chest pain. A chest x-ray will show a mass containing air-filled cyst. CT scan we can show the extent of the congenital cystic adenomatoid malformation and also associated problems or condition. Treatment is usually surgical removal. This is a CT scan of a 6 weeks old infant who presents with tachypnea. The CT scan showing here a solitary enlarged mass surrounded by microcyst and filled with air. This is a classic presentation of congenital cystic adenomatoid malformation. Primary ciliary dyskinesia. It is an autosomal recessive condition because of abnormal ciliary motion and impaired mucociliary clearance, so they cannot clear their secretion and will be retained and cause infection. Associated with partial or complete situs inversus, or you will see in this case the heart on the right side instead of the left. May be associated with male infertility. Some patients may have asplenia or polysplenia with immune dysfunction. Clinical presentation. 100% of the children with primary ciliary dyskinesia, they present with productive cough, sinusitis, and otitis media, and usually recurrent or chronic. Lower lobe bronchiectasis, frequent wheezing, and may be treated as asthma. Diagnosis of primary ciliary dyskinesia. In electron microscope you will see abnormal cilial ultrastructure. CT scan will show or may show sinusitis and bronchiectasis. Treatment is chest physical therapy, antibiotics for infection. Surgery, you will do tympanostomy if there is otitis media with effusion, nasal lobectomy if there is any. Rarely may require lobectomy or removal of one of the affected lobe. Bronchiectasis is a destruction of airway wall, bronchi, and bronchioles, so they become weak, dilated, and easy to collapse. The causes or the most common causes of bronchiectasis: cystic fibrosis is the most common cause, ciliary dyskinesia, infections, for example tuberculosis, Pseudomonas adenovirus, obstructive airway disease, for example retained foreign body. Clinical presentation of bronchiectasis: productive cough. This is the most common, productive cough. So chronic productive cough, crackles, wheezing, rhonchi, digital clubbing. This is one of the things associated with digital clubbing. Diagnosis: CT scan is the most helpful study in the cases of bronchiectasis. Pulmonary function testing, chest radiograph. The treatment of the cause. Bronchopulmonary dysplasia, it's a chronic lung disease of extreme premature infants because of prolonged ventilation, oxygenation, volutrauma, barotrauma from positive pressure ventilation. Clinical presentation: tachypnea, tachycardia, increased respiratory effort, and frequent desaturation. This is important, frequent desaturation. Diagnosis: arterial blood gas, pulmonary function test. The characteristics of a chest x-ray: you will see decreased lung volume, areas of atelectasis and hyperventilation, pulmonary edema, and interstitial emphysema. Management of bronchopulmonary dysplasia: surfactant in preterm infants after birth. Ventilate gently. Permit hypercapnia or slight elevation of CO2. Manage oxygenation to preserve function, but no over-oxygenation to prevent retinopathy. Diuretics for pulmonary edema. Monitor for complication, for example, pneumothorax. PDA should be treated if it's present. Pulmonary hypertension you should watch for, and treat associated GERD if present. Pulmonary hemosiderosis. It's a repeated episodes of intra-alveolar bleeding, and this will cause abnormal accumulation of the iron as hemosiderin in the alveolar macrophages, and this will cause pulmonary fibrosis and severe anemia. So the key in this case, in the cases of pulmonary hemosiderosis, a child present with pulmonary symptoms and severe anemia. So pulmonary symptoms with severe anemia. The most common cause of pulmonary hemosiderosis is idiopathic pulmonary alveolar hemosiderosis, which is the cause is unknown. Cardiovascular secondary to congestive heart failure, inflammatory or autoimmune, for example, Goodpasture syndrome or Wegener granulomatosis, Henoch-Schönlein purpura. Also can be associated with cow's milk hypersensitivity and is well known as Heiner syndrome. Clinical presentation of pulmonary hemosiderosis: iron deficiency anemia, hemopsis. So if you have a child present with iron deficiency anemia and hemopsis, this is highly suggestive of pulmonary hemosiderosis. Also can present with wheezing, bronchospasm, cough, dyspnea, alteration of blood gas, can be asymptomatic to shock or even death. Diagnosis of pulmonary hemosiderosis from the clinical presentation: the lab, you will see hypochromic microcytic anemia, elevation of plasma bilirubin. On the x-ray, you will see infiltrate, usually bilateral, but may spare the epices and may be associated with hyperaeration or area of hyperaeration. If you do allergy test, you may see positive for cow's milk protein antibodies and elevated IgE in the cases of Heiner syndrome. Stool specimen may be positive for heme, urinalysis for nephritis, ANA for autoimmune diseases. ANCA will be positive in the cases of Wegener's granulomatosis, and anti-GBM will be positive in the cases of Goodpasture syndrome. Lung biopsy if associated with diffuse alveolar hemorrhage. Treatment is supportive. Corticosteroid is the treatment of choice for idiopathic pulmonary hemosiderosis and is highly dependent also in the underlying cause. Sarcoidosis is a non-caseating granuloma multisystemic disease, and it's more common in African American. Approximately 5% of the cases are asymptomatic and can be detected incidentally when you do chest radiography, and you will see the bilateral lymphadenopathy or bilateral hilar lymphadenopathy. Systemic complaint: they may have fever, anorexia. Also may complain of dyspnea on exertion, cough, chest pain, hemopsis. Crackles may be audible. Anterior or posterior granulomatous uveitis, erythema nodosum. Diagnosis of sarcoidosis: a chest x-ray will show bilateral hilar or mediastinal adenopathy. Pulmonary function tests can be normal or may show restrictive plus or minus obstructive pattern. Hypercalcemia, hypercalciuria, elevated alkaline phosphatase level, elevated angiotensin converting enzyme level. Management of sarcoidosis: asymptomatic patients may not require treatment. Patients with minimal symptoms, they need close follow-up. Corticosteroids is helpful in selective cases. Cystic fibrosis is a disease of exocrine gland. It is the most common life-shortening or early death autosomal recessive disease due to mutation of long arm of chromosome 7. There are more than 1,500 different mutations. The most common one is F508 deletion. F508 deletion. Pulmonary symptoms of a child with cystic fibrosis is cough, chronic cough. So any child present with cough more than 6 weeks should be tested for cystic fibrosis. The cough can be dry, but more frequently is productive. Increased anteroposterior diameter of the chest, hyperresonance, scattered and localized crackles can be associated with clubbing, cyanosis, acute sinusitis, and nasal obstruction because of nasal polyp. Can present also with rhinorrhea, nasal polyps. Nasal polyps are red flag for cystic fibrosis. Also, as the lung disease progresses, you will see the child will have exercise intolerance, shortness of breath, growth failure, may be associated with corpulmonale, which is rare, respiratory failure, and death. Common pathogens is Staph aureus and Pseudomonas aeruginosa. Meconium ileus is the most common GI presentation in a newborn after birth. So they are born with meconium ileus or failure to pass meconium in the first 48 hours and associated symptom. 15 to 20% of newborn with cystic fibrosis, the ileum is completely obstructed. They present with abdominal distension, emesis, failure to pass meconium in the first 24 to 48 hours. KOB in this case will show air fluid level with ground glass material in the central abdomen. Gastrographene enema is diagnostic and therapeutic in cases of meconium ileus. Hypertonic solution can be used but can cause electrolyte problem. Surgery if medical management fails to prevent rupture and peritonitis. Pancreatic insufficiency will present with failure to thrive because of malabsorption, because of lack of endogenous digestive enzyme. The stool here will be a foul, bulky, greasy stool and flatus as well. Fat soluble vitamin deficiency, vitamin A, D, E, and K. They will present with a night blindness because of vitamin A, decreased bone density because of vitamin D, neurologic dysfunction, dementia, peripheral neuropathy, hemolytic anemia because of vitamin E deficiency, hypoprothrombinemia suggestive of vitamin K deficiency. Sexual development is typically delayed 2 to 3 years. Delayed time to conception may be associated with azoospermia. Sexual function is unimpaired. Patients with cystic fibrosis may present with distal intestinal obstruction syndrome because of obstruction of the intestine with thickened stool, and this can cause vomiting and abdominal pain. This is because of poor enzyme replacement adherence and typically occurs in teens. Rectal prolapse, nasal polyps are red flag for cystic fibrosis. Depression because of chronic illness, biliary cirrhosis. Also, you need to know that cystic fibrosis may be present also with diabetes, or diabetes can be a complication of cystic fibrosis and is well known as cystic fibrosis related diabetes mellitus. Diagnosis of cystic fibrosis. Newborn screen is the first test can be done when the child is born, and can be successful in detecting many cases of cystic fibrosis before even any symptoms. But if you have a child with suspected cystic fibrosis, which test you will do? Genetic test or a sweat chloride? Of course, a sweat chloride. Sweat chloride is the gold standard test. Sweat chloride is the gold standard test for the diagnosis of cystic fibrosis. More than 40 is in less than 6 months is diagnostic. More than 60 in a child more than 6 months of age is diagnostic. Positive results should be confirmed, and negative results should be repeated if you're still suspicious about the diagnosis of cystic fibrosis. False positive can be associated with a skin problem in general. For example, eczema contaminated with cream or lotion. Non-cystic fibrosis condition associated with positive sweat chloride test. For example, untreated adrenal insufficiency, ectodermal dysplasia, hereditary nephrogenic diabetes insipidus, G6PD, hypothyroidism, and malnutrition with hypoalbuminemia and edema. These conditions can be associated with positive sweat chloride test in a child actually do not have cystic fibrosis. Genotype or DNA testing is recommended for individuals with a positive family history and for couples planning a pregnancy. It is not necessarily indicated for the general population. Pancreatic function testing, fecal elastase, and 3 days stool fat measurement. No spot fat measurement in stool. This is more accurate, 3 days stool fat measurement in stool. Treatment for cystic fibrosis may include the following: pancreatic enzyme replacement or supplementation, multivitamins, including fat-soluble vitamins, bronchodilators, hydrating agents, mucolytics like DNase, and nebulized inhaled oral or intravenous antibiotics. Treatment of acute exacerbation of cystic fibrosis, hospital admission, antimicrobial oral and inhaled, IV antibiotics, anti-inflammatory medications, nutritional support. The median cumulative survival in the cases of cystic fibrosis is exceeding 35 years of age. Male survival better than female with no apparent reason. Infants born now with cystic fibrosis, center care based, likely to survive beyond the age of 50. There is no survivor in their 80s now. Obstructive sleep apnea. If the child just snoring with no apneas is well known as primary snoring. It is not associated with obstructive events and no gas exchange abnormalities. In cases of obstructive sleep apnea, the child will have apneas, means they stop breathing, and hypopneas, and often with arousal. So they have bad sleep, they cannot sleep very well. So during the day they are tired and sleepy. Also they have gas exchange abnormalities because of retention of CO2. So they will have metabolic alkalosis and respiratory acidosis, hypoventilation. This can cause pulmonary hypertension, and if it's not treated or prolonged can be complicated with right-sided heart failure. So it is a serious condition, obstructive sleep apnea. Risk factors and conditions associated with obstructive sleep apnea: adenotonsillar hypertrophy, which is large tonsils and adenoid; obesity, of course; craniofacial abnormalities, specifically mid-face hypoplasia and micrognothia; hypotonia, for example Down syndrome; neuromuscular diseases, cerebral palsy. Clinical presentation: loud nightly snoring with observed apnea spells; chronic mouth breathing with chronic nasal congestion; sleep is abnormal, they extend their neck while they are sleeping; morning headache; excessive daytime sleepiness; and mood changes. Very important to know that children with obstructive sleep apnea may present with ADHD-like symptoms. So before starting the medicine or stimulant for ADHD, ask about obstructive sleep apnea and the pattern of sleep. It is very important. Nocturnal enuresis. Obstructive sleep apnea can be associated with a nocturnal enuresis. So this means if you treat obstructive sleep apnea, you will correct and you will treat the nocturnal enuresis. So if any child presents with nocturnal enuresis, you have also to ask about sleep pattern and apneas during sleep. Adenoid face, also the obstructive sleep apnea can be associated with allergic rhinitis. Pulmonal and systemic hypertension is rare in children. Management of obstructive sleep apnea. All children should be screened for snoring in routine exam, or if they are presenting with symptoms related to obstructive sleep apnea. For example, ADHD, nocturnal enuresis, very important not to miss that. Polysomnography is the diagnostic test of choice for obstructive sleep apnea. Adenotonsillectomy is the first line of therapy if the tonsil and adenoid are enlarged. Non-invasive positive airway pressure in other cases. Post-operative complication is pulmonary edema. Apnea. Causes of apnea: the central apnea because of inadequate medullary responsive with no or poor muscle coordination for breathing. This is central apnea. Idiopathic apnea is the most common cause. So it means that we don't know the cause of this type of apnea. Prematurity is associated with apnea. Infection, GI reflux, seizures, arrhythmia, and child abuse. ALTI or sudden infant death syndrome. GERD is the most common association for awake ALTI. Seizure, second most common association with sudden infant death syndrome. Respiratory thrombosis and RSV are the third most common cause. So sometimes a child with a positive RSV can present with apnea before the symptoms of bronchiolitis start. High index of suspicious for child abuse is very important. Observation, testing, and treatment as supported by history and physical exam. National recommendation on SIDS prevention. Back to sleep. All infants less than 1 year, they have to sleep in their back. No sleeping in the tummy or the abdomen. And there is a decline in SIDS or sudden infant death syndrome after this recommendation was applied. Back to sleep. Tummy time while awake. So you have to be watching the infant when you place them in their tummy, and they have to be awake. No smoking prenatally or postnatally. Recognize the risk factors: prematurity, low birth weight, co-sleeping with parents, prompt sleeping or sleeping in the abdomen, overheating, young maternal age, smoking during pregnancy, late or absent prenatal care. National recommendation on pacifier. Pacifier, it is actually recommended to use and actually associated with lower risk of sudden infant death syndrome. So pacifier, once the breastfeeding is been established, you start giving the pacifier. So offer it at bedtime or nap time. No correlation between the pacifier use and the length of breastfeeding. So do not worry about breastfeeding when you use the pacifier. Apnea monitor, know that apnea monitor do not reduce the risk of SIDS. Pictus excavatum or funnel chest. Common associated condition with pictus excavatum, Marfan or Ehlers-Danlos syndrome. Spinal muscular atrophy. Clinical presentation, most of the cases are asymptomatic. In severe cases, when the depression of the chest is more significant, may become symptomatic. Suggested investigation for pictus excavatum, chest x-ray, EKG may show a WBW and lateral axis deviation. Treatment based on the severity or deformity and physiologic compromise. Corrective surgery if significant physiologic compromise, but asymptomatic cases, surgery is not recommended. This is a picture of a child 12 years old with pictus excavatum and with no symptom, just an isolated condition. So it's just cosmetic, but no other problem with this child. Pictus carinatum or pigeon chest is the opposite of pictus excavatum. It is anterior displacement of the mid-sternum and adjacent to costal cartilage. Clinical presentation rarely cause limitations. Physical appearance is the most common complaint. Treatment surgery for cosmetic and physiologic stress only, but otherwise reassuring the family the child is normal and do not require surgery. This lecture is only for educational purpose, not intended for direct care for any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. Thank you.